Hello, everyone. My name is Dr. Sandeep Vaghulde. I would like to thank you all for your time. I will be discussing impact of community services in rural, urban and school health in Unit 5 of Social and Preventive Pharmacy for Final Year B Pharmacy in Semester 8. Impact of community services in rural, urban and school health is a part of national health programs and it will covers functions of PHC, that is primary health care, improvement in rural sanitation, national urban health mission and health promotion and education in school. Total marks allotted for Unit 5 is 18 marks as per the blueprint of University of Mumbai. Introduction to community services in rural health in India. The healthcare infrastructure in rural areas has been developed as a three-tier system as follows. First is sub-center, in which most peripheral contact point between primary health care system and community manned with one female health worker and one male health worker. Second is primary health center, PHC, in which a referral unit for 6 sub-centers with 4 to 6 bedded manned with a medical officer in charge and 14 subordinate paramedical staff. And third is community health center, CHC, a 30-bedded hospital or referral unit for 4 PHCs with specialized services. The population norms for rural healthcare infrastructure in India are as follows. For one sub-health center for every 5,000 people in plains and 3,000 people in hilly and tribal areas. For one primary health center for every 30,000 people in plains and 20,000 people in hilly and tribal areas. For one community health center for every 1,20,000 people in plains and 80,000 people in hilly and tribal areas. The average population covered by a sub-center, primary health center and community health centers are 5,616, 35,567 and 1,65,702 respectively as on 31st March 2019. What are sub-centers, SCAs? The sub-center is the most peripheral and first contact point between the primary health care system and the community. Sub-centers are assigned tasks relating to interpersonal communication in order to bring about behavioral change and provide services in relation to maternal and child health, family welfare, nutrition, immunization, diarrhea control and control of communicable diseases programs. Each sub-center is required to be manned by at least one auxiliary nurse midwife, ANM, female health worker and one male health worker. Under National Rural Health Mission, NRHM, there is a provision for one additional second ANM on contract basis. One lady health visitor, LHV, is entrusted with the task of supervision of 6 sub-centers. Anganwadi worker. Under the Integrated Child Development Services, ICDS, scheme, there is an Anganwadi worker for a population of 1,000. There are about 100 such workers in each ICDS project. The Anganwadi worker is selected from the community and she undergoes training in various aspects of health, nutrition and child development for 4 months. She is a part-time worker and paid an honorarium of 200 rupees to 250 rupees per month for the services. Function of Anganwadi worker. Provide basic health care to new and expectant mothers in MCH, that is, maternal and child health. Create awareness about health referral services, also arrange immunization sessions for children, that is immunization education. Use of safe water and basic sanitation. Refer children to specialized care if they are ill, malnourished or disabled. Identify malnourished children under 5 years old and provide supplementary nutrition. Monitor the growth of children under 5. Provide supplements to children. Provide awareness about family planning. One of the key components of the National Rural Health Mission is to provide every village in the country with a trained ASHA or accredited social health activist, selected from the village itself and accountable to it. ASHA must primarily be a woman resident of the village, married or widowed or divorced, preferably in the age group of 25 to 45 years. She should be a literate woman with formal education up to class 8. Why ASHA scheme? ASHA will be chosen through a rigorous process of selection involving various community groups, self-help groups, Anganwadi institution, the Black Nodal Officer, District Nodal Officer, the Village Health Committee and the Gram Sabha. ASHA will have to undergo services of training episodes to acquire the necessary knowledge. The ASHAs will receive performance-based incentives. ASHAs empowered with Drucket. ASHA will create awareness in health and nutrition. Primary Health Center, PHC. PHC is the first contact point between village community and the medical officer. The PHCs were envisaged to provide an integrated curative and preventive health care to the rural population with emphasis on preventive and promotive aspects of health care. The PHCs are established and maintained by the state governments under the Minimum Needs Program (MNP), Basic Minimum Services (BMS) program. As per minimum requirement, a PHC is to be manned by a medical officer supported by 14 paramedical and other staff. Under NRHM, there is a provision for 2 additional staff nurses at PHCs on contract basis. It acts as a referral unit for 6 sub-centers and has 4 to 6 beds for patients. The activities of PHC involve curative, preventive, promotive and family welfare services. Elements of primary health care. Education about prevailing health conditions and methods to prevent and control them. To promotion of food supply and proper nutrition. To provide adequate water supply and basic sanitation. Maternal and child health care with family planning. Immunization against major infectious diseases. Prevention and control of locally endemic diseases. Appropriate treatment of common diseases and injuries. Provision of essential drugs. Functions of PHCS. Health programs. MCH care and family planning. Medical care. Health education and training. Referral services. Safe water supply and basic sanitation. Prevention and control of locally endemic diseases. Collection and reporting of vital events. Basic laboratory services. Community services in urban health in India. National Urban Health Mission, NUHM, was approved by the Union Cabinet on 1 May 2013 as a submission under an overarching National Health Mission, NHM, for providing equitable and quality primary health care services to the urban population with special focus on slum and vulnerable sections of the society. NUHM seeks to improve the health status by facilitating their access to quality primary health care. NUHM covers all the cities and towns with more than 50,000 population and district and state headquarters with more than 30,000 population. Urban health program is being implemented through urban local bodies, ULBs, in 7 metropolitan cities like Mumbai, New Delhi, Chennai, Kolkata, Hyderabad, Bengaluru and Ahmedabad. For the remaining cities, the State Health Department decides whether the urban health program is to be implemented through Health Department or any other urban local body. Urban health statistics for the structure and current scenario. NUHM envisages setting up of an organized service delivery infrastructure which is largely absent in cities towns to specially address the healthcare needs of urban poor, though this secondary and tertiary care facilities are available. The emphasis is to improve the existing public health delivery system with a thrust on upgrading the existing health facilities in terms of infrastructural equipment, also establishing new health facilities wherever necessary by providing special care as well as strengthening emergency response systems and making available adequate health human resources. Key components of NOM. NOM is designed to provide health services at the facility and community level. Urban health care delivery model envisages following components. Urban health care delivery models in India include primary health centers, community health centers, and health and wellness centers. The goal is to provide accessible, quality care to all residents, especially vulnerable populations. Primary health centers. Urban primary health centers, UPHCAs provide comprehensive primary health care to vulnerable populations. Urban health and wellness centers, UHWCAs provide preventive, promotive, and curative services. Community health centers. Urban community health centers, UCHCAs provide primary health care, inpatient services, and surgical facilities. Other models includes outreach services, provide care through mobile medical units, health camps, home visits, and community-based interaction. Polyclinics provide comprehensive primary health care. In order to provide comprehensive primary health care services, the National Urban Health Mission aims to establish urban primary health care centers, not as a standalone health facility, but as a hub of preventive, promotive, and basic curative health care for its catchment population. The package of services envisaged at UPHC inclusive of preventive, promotive, curative, rehabilitative, and palliative care. Further, in order to strengthen comprehensive primary health care across the country through Ayushman Bharat HWCAs, states are upgrading their sub-centers and primary health care centers as health and wellness centers, HWCAs, across rural and urban areas. As on 31st March 2019, there are 3,302 at the level of sub-centers is functional in the urban areas of the country. Service provision. The UPHC's key responsibility is to provide comprehensive preventive, promotive, curative, rehabilitative, palliative care. Services provided by UPHC include OPD consultation, laboratory services, drugs and contraceptive dispensing, delivery of reproductive and child health (RCH) services, preventive, promotive and curative aspects of communicable and non-communicable diseases, multi-specialist services, minor surgical procedures, counseling and help desk, outreach activities, population-based screening. Community services in school health. School health service is an important aspect of community health. It is possible to increase the health level of community and achieve growth in the health of future generation through school health service. School health refers to a state of complete physical, mental, social and spiritual well-being and not merely the absence of disease or infirmity among pupils, teachers and other school personnel. The ultimate aim of school health services is to promote, protect and maintain health of school children and reduce morbidity and mortality in them. Objectives of community services in school health. The promotion of positive health. The prevention of diseases. Early diagnosis, treatment and follow-up of defects. Awakening health consciousness in children. The provision of healthful environment. What is need for school health services? School children constitute a vital and substantial segment of population. School children are vulnerable section of population by virtue of their physical, mental, emotional and social growth and development during this period. School children are expressed to various stressful situations. Children coming to school belong to different socio-economic and cultural background which affect their health and nutritional status and require help and guidance in promoting, protecting and maintaining their health and nutritional status. Children in school age are prone to get specific health problems. Components of school health program. A school health program can include physical education, nutrition, health care, mental health, and other services. Health appraisal of school children and school personnel. Remedial measures and follow-up. Prevention of communicable disease. Healthful school environment. Nutritional service. First aid and emergency care. Mental health. Dental health. Eye health. Health education. Education of the handicapped children. Maintenance and use of school health records. Improvement in rural sanitation. Sanitation is the hygienic means of promoting health through the prevention of human contact with the hazards of waste as well as the treatment and proper disposal of sewage and wastewater. Hazards can be either physical, microbiological, biological or chemical agents of disease. It was in this context that the Central Rural Sanitation Program, CRSP, was launched in 1986 primarily to improve the quality of life of the rural people and also to provide privacy and dignity to women. Why sanitation and hygiene needed in India? Sanitation and hygiene are important in India because they help prevent the spread of disease and infection and improve health. Why sanitation is important? Poor infant and child health. Inadequate sanitation facilities are linked to poor infant and child health. Waterborne diseases it shown by 25 lakhs diarrhea deaths globally and 6 lakhs in India alone. Poor sanitation is linked to the transmission of waterborne diseases like cholera, dysentery, typhoid, and intestinal worm infections. Deaths due to 60,000 roundworms and 65,000 hookworm. Why rural sanitation? The concept of sanitation broadly includes liquid and solid waste disposal, personal and food-related hygiene, and domestic as well as environmental hygiene. Most of the people still defecate in the open space. Most of the villages lack waste disposal and drainage systems and many in the villages are ignorant about the consequences of poor sanitation and unhygienic conditions. As a result, many people suffer and even die of diseases caused by unhealthy practices of personal and environmental hygiene. Vision of Government of India. All Indian cities became totally sanitized, healthy and livable and ensure good public health and environmental outcomes for all their citizens with a special focus on hygienic and affordable sanitation facilities for poor. Measures to improve sanitation in rural areas. The Environmental Hygiene Committee, 1948 recommended that 90% of the country's population should be covered with water supply and sanitation facilities within a period of 40 years for which the national program was to be initiated. Introduction of Sanitation Program in the Health Sector, 1954. Role of National Water Supply and Sanitation Program. The government launched the program as part of the first 5-year plan, 1951 to 56. The first 5-year plan had a provision of 6 crores rupees for rural water supply and sanitation programs. Transfer of Rural Sanitation Program to the Department of Rural Development from the Ministry of Urban Development, 1985. Rural sanitation was included under the Minimum Needs Program (MNP) in 1987. Central Rural Sanitation Program (CRSP), a centrally sponsored rural sanitation program, launched in 1986. The CRSP is implemented in different states and union territories for improving sanitation facilities through construction of sanitary latrines for individual households. The program provided 100% subsidy for construction of latrines for SCAs, STs, and landless laborers and subsidy as per the rates prevailing in the states for the general public. Central Rural Sanitation Program (CRSP), a centrally sponsored rural sanitation program, launched in 1986. The CRSP is implemented in different states and union territories for improving sanitation facilities through construction of sanitary latrines for individual households. The program provided 100% subsidy for construction of latrines for SCAs, STs, and landless laborers and subsidy as per the rates prevailing in the states for the general public. A Rural Sanitary Mart (RSM) is a store that sells materials and services for sanitation and hygiene in rural areas. The mart is a commercial venture with a social objective. What does a rural sanitary mart sell? It sells toilets, borewells, gobar gas, soap, mosquito nets, mosquito coils, toothpaste, nail cutters, washing soda, and water filters. Who operates a rural sanitary mart? NGOs, SHGs, women organizations, and panchayats. The goal of a rural sanitary mart is to promote sanitation and hygiene in rural communities, to educate residents on the importance of installing sanitary toilets in their homes, and to construct school toilets, public toilet blocks, and community toilets. Nirmal Gram Puraskar. The Nirmal Gram Puraskar is given to Gram Panchayats that do excellent work for cleanliness in the village. This award was initiated by the Government of India in 2003 and was first presented in 2005. This award is given by the Department of Drinking Water Supply and Sanitation, which comes under the Ministry of Rural Development. In October 2003, elected local representatives of Gram Panchayats were involved to promote collective community action through sanitation. NGP awards were given to districts, blocks, and Gram Panchayats that have achieved 100% sanitation coverage of individual households, 100% school sanitation coverage, and free from open defecation and clean environment. Nirmal Bharat Abhiyan. Nirmal Bharat Abhiyan (NBA) was a campaign of the Government of India. The aim of this campaign was to improve the sanitation situation in rural areas. This campaign is also called the Total Sanitation Campaign. Total Sanitation Campaign closed in 2012 after striving for 13 years in achieving universal rural sanitation coverage. In 2012, Nirmal Bharat Abhiyan started for community-led and people-centered approach (IEC), solid and liquid waste management. This program emphasized on a new approach of awareness by linking it with the current sponsored schemes of Government of India. A health promoting school (HPS) is one that constantly strengthens its capacity as a healthy setting for living, learning and working. Health promotion refers to activities that increase well-being and enhance wellness or health, definition given by Pender, Murdoch, and Parsons, 2006. These activities lead to actualization of positive health potential for all individuals, even those with chronic or acute conditions. Examples include providing information and resources in order to enhance nutrition at each developmental stage, integrate physical activity into the child's daily events, provide adequate housing, Promote oral health. Foster positive personality development. What is a health-promoting school? Fosters health and learning with all the measures at its disposal. Engages health and education officials, teachers, teachers' unions, students, parents, health providers and community leaders in efforts to make the school a healthy place. Strives to provide a healthy environment, school health education, and school health services along with school community projects and outreach, health promotion programs for staff, nutrition and food safety programs, opportunities for physical education and recreation, and programs for counseling, social support and mental health promotion. Implements policies and practices that respect an individual's well-being and dignity, provide multiple opportunities for success, and acknowledge good efforts and intentions as well as personal achievements. Strives to improve the health of school personnel, families, and community members as well as pupils, and works with community leaders to help them understand how the community contributes to, or undermines, health and education. Growth and developmental surveillance in schools involves observing a child's development and skills over time. It's a collaborative process between the child's family and the school. It includes following parameters: nutrition, physical activity, oral health, eye and vision, mental and spiritual health, disease prevention strategies, vaccination, encourage health promotion activities, periodic health checkup.